Today's presentation for the Prepare Institute is from my friend and colleague, Rebecca Fielding Miller, and I'm just super honored that she's here. And today, she's going to be talking about who is translating, who is listening, values and praxis and translational research. Great title, thank you. Next slide. So Rebecca holds a PhD in behavioral sciences and health education from Emory and an MSPH in international health with a focus on social and behavioral intervention from Hopkins School of Public Health. She also served as a Peace Corps volunteer in South America and was a Fulbright scholar from 2013 to 2014. Her research is community driven and examines structural drivers for COVID-19, HIV, and gender-based violence in the US and sub-Saharan Africa, and a focus and intersection of race, gender, and economic inequality. And we're going to hear a lot about those things today, I hope. She's the principal investigator for the Safer at School Alert project, which rapidly translated and validated the use of COVID-19 wastewater surveillance in low-income elementary schools across San Diego County. So really thank you for doing all of that great work. And then I think I get to let her take it away.
Yep. All right, Rebecca, when you're ready, go ahead and share your screen and you go ahead.
Fabulous. So I'm really glad to be here. This is really fun. I always enjoy talking about the work that we've been doing over the last couple of years, and I'm going to say we a lot because I get to do the talking, but this was an enormous group effort on part of dozens and dozens of people. So thank you for letting me share all of our work today. So here's kind of an overview of what I'm going to talk about. I'm going to talk a little bit about sort of this distinction between translational research and implementation science, as I understand it, and then kind of give some examples with two different projects that we have been working on lately. One of them is not technically an infectious disease. I'm going to talk a little bit about gender-based violence, but I think that there are some really interesting things that we can learn from the implementation of that project and port back to all sorts of other public health and medicine research that we do. So when I talk about translational research and implementation science, this is what I mean, and I assume folks have seen a lot of this before, but the basic idea is that translational research is how do you get something from basic science in a lab to a clinician, to a medical setting, and ideally out to the public at large, whether or not they are even stepping into a clinician's office. And there's a lot of like numbers that run around for this, but there's kind of a guesstimate that on average it takes somewhere between 10 and 17 years from the time that somebody comes up with something in a basic science lab until it makes it all the way to bedside, to clinic. Obviously, that was vastly accelerated during COVID, a lot of it because of folks here. And, you know, we had vaccines in less than a year. There were phenomenal just sprints to getting therapeutics out the door. But in non-crisis situations, it's really more like 10 to 17 years. And so translational research is understanding kind of that process of that pipeline. And then sort of, you can kind of think of it as the end of that pipeline is really this idea of implementation science. And there are many people all across our campus who have a lot of expertise in implementation science, Borsa Caribbean and folks at ACTRI. But when I talk about it, what I mean is how do we take something that we're pretty sure works, is evidence-based, and get it set up in a new setting in a way that's sustainable. So how do we get mobile vaccine clinics to work in City Heights? How do we get group ARV collection to work in Mozambique? And there's a lot of things to understand about that in terms of what is the innovation itself that we're getting people to adapt. Who is it that's trying to sell this intervention to the community? Is there stakeholder involvement? All of this. So that's kind of the implementation side once you have something, and the translation side to get the thing from a basic science lab. These don't work perfectly for public health interventions, but we come from a biomedical background, so this is the framework that we're mostly using. This thing on the right, this implementation framework, is one of many, but it's the one I'm going to use today because it's annoying to switch frameworks. So the other thing I'm going to talk about is some really big words that are useful for Scrabble or, I don't know, annoying your brother-in-law over a glass of wine. And these ideas are ontology and epistemology and axiology. And I kind of stole this little framework from Anderson Carpenter on Black Lives Matter principles as an Afrocentric approach to improving Black American health. So basically, there's these three kind of ideas in the philosophy of science. One of them is ontology, which is what do we even mean when we talk about reality? And like this is relevant to COVID. I'm going to get there, I promise. Um, what do we mean when we talk about reality? Are we talking about certain events? Are we talking about certain objects? What is the nature of the thing that we're even trying to study? The other kind of big idea that I think is pretty important is epistemology. And I think this is a term that we hear more often, but epistemology is what even counts as knowledge. What's a valid way of creating valid knowledge? So in biomedical sciences, in public health, we come from this very positivist framework. Positivist means we're pretty sure there's an objective reality. We're pretty sure we can measure it. And more specifically, we are pretty sure that if we create a falsifiable hypothesis, we can at least demonstrate that something is not true. And the more we demonstrate that other hypotheses are not true, the more we get to what actually is true. This idea of a falsifiable hypothesis, usually tested through a randomized control trial as kind of the gold standard for what we know and don't know in biomedical research. But there's other epistemologies out there, some kind of close cousins, some a lot further away. So for example, if you did a lot of your training somewhere, if you had a lot of overlap in like anthropology or sociology, you might have come across this idea of a constructivist epistemology. And that leans more into the idea that like, well, like, you know, reality is kind of a social construct. It's just a thing we're all doing together. And like, that sounds weird, but I put to you money and like rent. Like, kind of money's not real, right? Like, we all decided it's real. And it functions very really, but like, technically, it's just a thing everybody came up with and agreed is true. So, a social construction of reality. A lot of us who do kind of the more social sciencey stuff in public health lean more towards something called post-positivism, which is like, yeah, there's probably an absolute reality, but I don't think we can actually measure it. So like, there's definitely a thing called stigma, but all of these scales that we have, all these cool things that like Dr. Smith is working on, they kind of like just get at and surround the idea of whatever stigma is, and we keep trying to get closer to it with scales and interviews, but we'll never exactly nail it. That's epistemology. There's different things that count as knowledge. So a scale counts if I can validate it, if it's got a really high coefficient, all of these things. And then the last thing, and I think something that we never talk about, is this idea of axiology, which is what do we value? What's important? And this is really implicit in a lot of what we do, right? Like we value people being healthy. Why? Right? Like why do we all spend our lives doing this? But a lot of us are really dedicated to this work. And so what are the values that underlie this work? And how do they guide our epistemology? How do they guide the questions that we choose to ask and the way that we choose to answer them? This will become important in a second, I promise. We'll loop back here. So Davey mentioned, and I think a lot of you have heard me talk a lot about SASE, the Safer at School Early Alert Project. And I'm going to talk about SASE as a translational project real quick. So SASE is a community engaged project. We wanted to really rapidly translate the amazing research happening here at UCSD to communities that were really being hit the hardest by COVID. We wanted to create a preferential option for the communities that needed it most. And we thought about it, and we really came up with kind of a founding idea for SASE, which is that we believe that all children and their families have the right to feel safe at school, regardless of their neighborhood, their background, or their finances. And that was always the underpinning of this project. So SASE was implemented. If you look here, you can see a map, sort of an old redlining map of San Diego, which is fun. Here's sort of all the neighborhoods kind of south and east of Balboa Park. Here is, I think, what was once Frontier, maybe. Here's kind of like your North Park, your University Heights, your kind of so-so neighborhoods. These were neighborhoods that were very deliberately set up to be exclusionary. This is where sort of the less desirable, I think it actually says that, people were supposed to live. And if you look at maps of where COVID was happening, you can see quite a lot of overlap. These areas that are purple are areas that had some of the highest case rates of COVID-19, some of the most poverty. Um, and I think a lot of us looked at these maps of COVID in the county over and over again, and you can see this parallel between areas that have been historically marginalized on purpose, right? Like this is like a real estate map. This was people's activities did this, and we can still see these same patterns in terms of where people are getting COVID now in San Diego. And those of us who do HIV research, you know, we see very similar patterns, right? Folks who have been historically legally pushed to the margins are folks who are also at higher risk of HIV, and that's not a coincidence. Vulnerability on its own is a social construct. So we wanted to take this UCSD project and we wanted to very purposefully put it at the service of communities that had been made vulnerable for social reasons. So SASE, like I said, it built on Return to Learn. We put wastewater monitors like you see all over campus on school campuses. The number depended on the year, usually about 10 to 26. Um, and we worked really closely with the schools and principals to make sure that we were executing this in a way that felt good to them. The kids were really into it. They would often decorate like the little, we called them robots, which is why you see Leonard up here on the right. Leonard is our mascot. So here's one the kids decorated as Harry Potter in the rancid water. The greatest, what does it say? The greatest student from Botwarts. This one's my favorite. And here's another example of it with Harry Potter uncovered. We also kind of got to have like this living laboratory where instead of going from bench to bedside, teachers would say, well, what if? And, you know, Rob Knight and his amazing graduate students would say, I don't know, let's try it. So for example, one of Rob's grad students was really interested in surface sampling. Can we pick up COVID from the floors? And we said, I don't know, let's try it. And so teachers would actually collect 2 samples on the from the floor of the classroom at the end of every day, take it to Rob's lab, and sure enough, we could detect COVID. What we realized though, or what the teachers realized, is one of the teachers got curious and she went into her classroom after it had been quarantined for about 10 days. She took a sample on the floor, sent it to the lab, and it came up positive. And we said, oh, COVID appears to linger in carpet for a really long time. We would have had no way of knowing that if a teacher hadn't just been curious and checked it out. And so in real time, we kind of changed our protocol and our approaches to be more appropriate to like just the materials in a classroom. And that was a matter of one academic year to the next, which I just think was really cool. We also tried to be really thoughtful about making sure that this was an integrated system. So we weren't just collecting data about whether or not this was possible. We were making a public health system in real time. So we gave the information back to the schools immediately with like 24 to 36 hour turnaround. And we didn't just tell them, hey, we think you have a case of COVID on your campus. We also tried to provide a lot of actionable information for what to do about it, because we obviously were simultaneously doing a lot of focus groups and collecting surveys, and we pretty consistently heard that these were in very low income schools, and about 1 in 5 parents told us pretty consistently, like, I can't afford to isolate for 5 days or 10 days. There's no point in getting tested because I can't do anything about it. And so we worked really closely with the county and tried to put materials together in English and Spanish to take some of the sting out of that isolation and quarantine to make it more accessible as best we could. And one thing that was really valuable is when we asked people, you know, what are some sources of information that you really trust about COVID? Obviously, pediatricians came up. their teachers came up, but UCSD came up. People really, really trusted us as a source of information and as a partner. And I don't take that for granted. I know that that is not an inevitable outcome of an academic community partnership, that people say, wow, this academic partner is really trustworthy. That is perhaps more the exception than the rule. And so I thought that that was really valuable and important. Um, as many of you know, COVID is over, or at least the pandemic funding is over. And so we had to wrap up the wastewater monitoring, but we had a huge outpouring from parents who wanted to continue having this program on campus, who found it extremely valuable. This is actually a bunch of screenshots from the County Board of Supervisors website. So people like called in, they sent comments in, asking the county to continue funding the project because they had found it really valuable. One parent said, you know, it makes the invisible visible. It makes me feel safer. Um, and again, I don't take that for granted, that we did something that helped people feel better psychologically, as well as, you know, like validating some methods of surveillance, which is kind of nice. So we started with the premise from this that, okay, maybe we did something right. Maybe we did this sort of rapid community engaged translational science well. We didn't really have time to document it along the way because everything was crisis mode all the time. But you know, let's sit down, let's do a retrospective, let's understand what we did do well, maybe what we didn't do so well, lessons learned, and how we might want to do better in the future. And so we sat down as a team. There were about 3 or 4 full-time staff, undergrad employees. There were just a lot of us, quite a lot of us. And we had a couple of retrospective meetings, and we talked about, you know, what went really well, what didn't. How did people as staff feel that it went well? I was in some of those meetings. I was not in some of those meetings, so people would feel okay. Maybe mentioning ways that they as staff felt like things could have gone better. We reviewed all of our notes, of which we had many, and we tried to identify across all of that data some common themes about what this process of translation had been. These, by the way, are drawings. We asked kids about their perception of COVID in schools for sort of a sub component of this. And so these are pictures of kids holding hand sanitizer and wearing masks and being 6 feet apart under a cheerful sky. So one of the things that emerged immediately, and you might recognize this callback, is we talked about our values early and often in this project. And one of the very first things we did was kind of lay out a group ethos. And that was that just as a group, for SASE and for everything else, we wanted to be able to say that we use a community-centered research approach that prioritizes open communication, health equity, empathy, anti-racism, praxis, and stakeholder autonomy. And when I say praxis in particular, what I mean is the way that we went about our daily tasks as a team also upheld those things. So if I say that economic inequality is a cause of health disparities, but I'm not paying my staff a living wage, that's bad praxis. It means trying to live your values in your work just as much as in your manuscripts. So when we kind of reviewed our notes, there was sort of values underlying everything. And then there were kind of these big main themes that really emerged of how we managed to, we think, do a pretty good job. The first, I think you'll recognize this, is that it was an emergency. Everything had to go fast. Everybody was feeling flexible. Everybody was on the same page that this was something that required speed and required moving things from a lab to a community as quickly as possible. We had really flexible funding. This was funded through a really wonderful partnership with San Diego Health and Human Services Agency. We met with our funders every week. We had a really close relationship with them. And because we had that, that close and frequent contact, they were really on board with us kind of following where the pandemic was going, what we were learning, just being really flexible very quickly, agile, if you will. And internally at UCSD, we had really great resources. You know, obviously, Rob Knight's lab has been a phenomenal resource for a lot of us throughout this pandemic. We had the infrastructure of a brand new school of public health. There were expert colleagues that I could call on. There were students who were excited to participate in this. So we as UCSD, and I think as the Prepare Institute in general too, had resources, institutional infrastructure that could be called on to make this happen quickly. One thing that was really important that came out was that we had really strong relationships. I lived here in San Diego. We moved here in 2015. I live in San Diego, right? Like I participate in civic organizations with my family. I know a lot of people. Um, our One of our phenomenal co-investigators, Laura Cohn, had been doing early childhood education advocacy work for 20 years, and she knew everybody. And so it was very different for Laura to call up a principal than for me to call up a principal and say, hey, we're doing this thing at UCSD, are you interested? Because that trust and those relationships already existed, it really facilitated our entry into a lot of spaces. Our team, I think, did a really good job translating knowledge in both directions. So we were sort of the intermediaries. So for example, when a teacher said, hey, I noticed that this is happening in a classroom, we could immediately take that to the night lab, to the basic scientists and say, hey, teachers are noticing this. Like, what should we do about it? And conversely, when there were sort of ways of understanding what was and wasn't happening in the wastewater, our job was to translate that back to the community, literally like into Spanish or Arabic or whatever, but also in ways that were meaningful to the community. So we were able to act as this knowledge translation hub. And then we had really amazing champions across the board. So we had phenomenal champions in County Health and Human Services Agency. We had great champions in the School of Public Health with Cheryl, with Randy, the Dean of Business Affairs, and superintendents who really championed the project too, and health and wellness officers. And without those folks, and without the relationships to get to a place of trust with those folks, this just wouldn't have happened. And so when we put that all together, this is really what we saw is sort of this, these institutional resources at UCSD, this community context of a public health emergency and access to flexible funding, which I can't emphasize enough, but also the ability to bridge those things, to bring our institutional resources to the community in a way that was useful and important. It was absolutely necessary to have strong relationships across both groups, to have champions in both settings, to be able to translate back and forth across those two settings, and for all of that to be underpinned by values so that people really trusted us. Because I think without trust, none of this would have worked. Nobody's going to trust you with flexible funding if they don't trust what you're going to do with it. And so we can like lay this across some of our implementation science frameworks and kind of say, oh, here's the bridging factors, here's the inner context, here's the outer context. But for us specifically, this is really what we learned, is that we had to have our values were at the center of it. Our values are what led to relationships and champions, to people trusting us enough to do this work, and to us feeling like we were always centered in a way to do it well. We would know how to answer a question because we would go back and say, okay, will this result in more kids feeling safe at school? Yes, no. It was it's useful to have guiding principles that aren't always a falsifiable hypothesis. So now I'm going to move. You might recognize this map, and if you don't, you need to go see a movie that is excellent. So now we're going to move from San Diego to Eswatini, formerly known as Swaziland, in Southern Africa. And I'm going to talk a little bit about something that might not seem immediately the same, because it's gender-based violence and not an infectious disease, but there are lessons to be learned here. So this is another project that I was working on pre-COVID, a little bit during COVID, and someday post-COVID again. This is a sexual violence resistance intervention called #GameChangers. The girls named it Bagotuli Betinfo, which literally means they are changing the game in Siswati. And this is an evidence-based intervention that has been shown in Canadian context and US context to reduce women's experiences of sexual assault by up to 50% in at least the 12 up to 24 months following participating in it, which is wild. Like, this is literally the only intervention that's been shown to have this effect. And you'll notice that I use very specifically the language of resistance, and that's because this program is really predicated on the idea that the only person who can prevent sexual violence is the perpetrator. A person who has experienced violence is never at fault for that. They're just not. You can't prevent somebody else's behavior. Well, we as professionals try to, but like as an individual survivor, you couldn't have prevented it. But we do, this is about teaching strategies for resistance, for recognizing a risk scenario early, and coming up with strategies to keep yourself safe. And I think a lot of this, again, is similar to when we think about HIV and other infectious disease. There's a lot of these sort of thinking about individual strategies to address bigger structural drivers, and just working with the tools that we have in the absence of the revolution. So this was sort of a workshop style intervention, and we really wanted to understand the implementation of it. So now I'm talking about implementation science. And so we took this project, EAAA, from Canada to Eswatini. We adapted it a little bit, and then about 20 women participated in it before COVID happened. But we wanted to understand, even with those 20 women, like how did that implementation go, and how can we tweak it to make it better, to incorporate more HIV content for future, NIMH applications, and how can we generally make this a better fit for the context? So we use sort of an implementation science approach to understand this project. And what we really wanted to understand, we thought at the beginning, was how do facilitators and participants really perceive sexual violence after game changers? Because it's really meant to be sort of this radicalizing process. And so we interviewed some of the women, some of the facilitators who participated in it. We used a pretty typical qualitative analysis approach where we transcribed it and we developed code books by consensus. But we were really interested in this idea of power, because gender-based violence is about power. And this intervention is about sort of challenging power structures. And so we wanted to be thoughtful about power when we were doing this analysis. And so this is sort of what my amazing PhD student, Araz, this is how she noticed women were really conceptualizing this intervention, this program. There were sort of the more like distal outcomes, or distal drivers, risk drivers, and the more proximal risk drivers. And there were conversations or things that women brought up that were more sort of researcher driven, more grounded in the intervention itself, and things that were more participant driven. So for example, there's a component that involves physical defense skills, which is super fun. Like how to throw a punch, how to like send somebody's head through a wall, like if they're on top of you, like it's extremely fun. And like the girls love that. I love that. I should call them women, not girls. They were like 1920. It's very researcher driven. It's very scripted. It's very proximal. It is in the immediate event. Here's what you can do. But they also talked about sort of this much more distal, big picture stuff that the women were really interested in, which is sort of recognizing the social structure that they live in, the social norms, sort of gendered power hierarchies in general, how the police reacted to reports, that type of thing. And these were sort of very participant driven, very big picture conversations that honestly are hard to script, and in an intervention that really kind of targets the immediate interaction with a potential risky partner, don't really fit that intervention, but were still really important to the women. And then there was this kind of more immediate conversation that was participant driven, but kind of fit this more proximal framework for the intervention, where this idea of collective empowerment, of group dialogue, women talked about sort of having catharsis, of having other women that they could lean on, sort of having solidarity with one another. And so there's the really interesting thing that this suggests is that there might be a fourth quarter that's empty, because you can see this quadrant down here. And this didn't really come up, but when we thought about some of the interventions that we've seen, and I bet, again, those of you who work in HIV can think of some of these, there's this sort of like researcher driven talking about upstream stuff that's really quite patronizing. And we don't do this anymore, but like raising awareness about gender-based violence amongst women experiencing gender-based violence. Like that's actually pretty patronizing. Telling people who can't afford, healthy food that they should really be eating more kale. That's not helpful. It's kind of patronizing. And I think we all have maybe seen an example of this. I have certainly stumbled into doing it once or twice accidentally, tried to catch myself and fallen back, but not a great spot to be in. And so when we thought about the structure of this intervention, how it uses this kind of critical pedagogy framework that really encouraged students to name and critique the power structures around them, one thing really emerged about epistemology, I told you I was going to come back to it, and about this framework. Because this down here, this sort of blue thing, and honestly this orange thing, these are easy to replicate. You can do this with a handbook. You can give your provider a script for how to talk about things. You can bring people into a workshop once a week for 6 weeks. You can replicate it. And so you can evaluate it with an RCT, right? But this up here, this is really hard to replicate because it's built on participants having the power, not you. And so people will kind of go off and do their own thing, and that's really hard to replicate because you are giving people the space to name and critique power structures in a way that feels meaningful to them. And that's extremely hard to do with a script. So it's extremely hard to replicate. So it's extremely hard to validate with an RCT. So we don't work from an epistemology that lets us really dig into those big critiquing those big social structures that really are, a good bit of the problem, whether we're talking about COVID or HIV or gender-based violence. And so the other thing that I have been thinking about a lot lately, and that I'm kind of here to just invite you to think about with me, is I think another way that we can think about translation is that health and disease are in many ways a translation of power. And so Stephen Thrasher has written a really great book about this called The Viral Underclass, predominantly about HIV, but also about COVID, thinking about where do viruses tend to congregate, tend to end up in communities with less power. There's a lot of this from an amazing history of activism with HIV. The book and the documentary How to Survive a Plague really is a beautiful example of people without power engaging in like real political, bipartisan attempts to seize and manipulate power to save their own lives. Paul Farmer has written about this beautifully. Other not HIV examples include, for example, maternal mortality here in the US. We know that Black women have very little social and structural power, right? Because we exist in a system where like whiteness has more power, maleness has more power, and so to be a Black woman is to have less power. And one component of that is that a lot of Black women die in childbirth, and it is so little valued that we're not even counting it. And so this translation of power into health, I think, is something really important and something that I think at the core a lot of us are doing. And so I don't have conclusions or summaries. I have questions. And these are just the questions that I've been thinking about lately, which is what does it mean if we think about disease as a way of translating power? How should we think about praxis, about the way that we run our labs and our research, about the acts that we take in health disparity research? What does it mean if we're not paying a living wage or writing an MPH into every grant? And like the NIH has not like increased R01s for a long time. I'm not saying that's easy, but like, what does it mean to incorporate praxis into our own work? How else can we think about translation if it's not from bench to bedside, if it's not, a genius at a wet lab to a physician in a white coat? to, sort of a passive patient, which is kind of the traditional image, what else could translation imply? What would it look like if we acknowledged axiology? Because I would argue that there are values underlying all of our work. We just don't name it. And I think qualitative and sort of more anthropology aligned work has gotten a little bit better at sort of naming and reflecting on researcher positionality. But what would it look like if we all named the values that are underlying what we're doing? And I think a lot about what solidarity and liberation could look like as a tool for public health. And what epistemology would value that, because I don't think it's a randomized control trial. And so how do we kind of navigate that divide? I have no answers to any of those, but they are my questions for you. And I'm happy to stop there and just chat as much as you all like.
This was great. Thanks, Rebecca.
Yeah.
So I really liked how you framed these questions and then didn't answer them.
I don't have the answers.
So I guess we'll start with, how do we start to get those answers? What do you think are good routes for that?
Yeah, I mean, I think that I don't think it's any one person's process. I think it's very hard to shift anything by yourself. But so, for example, in my lab, we try to be really explicit about our conversations. We named our values. If you look at my lab handbook, when I bring on a new team member, the very first thing they see is us very explicitly naming our values. We have conversations about power structures on the regular and try to think about, all especially research. Most things that we do are probably either holding up or deconstructing some power structure. And so we try as often as we can to take a minute and think about, is what we're doing, is it supporting a power structure or is it dismantling it? And it's hard, right? I think it has to be a lot more people thinking about this and valuing this. We submitted a grant for participatory data analysis, or a participatory research project that had a component where folks like imagine a better world to do with housing or something. And one of the reviewers said, well, what if they imagine something that's not politically possible? And I said, well, then we figure it out. But I think it starts with being willing to even see that those power structures exist and to be willing to have those conversations, which can be really hard and scary. But the more that people do it, the not easier, but more normalized and more built in it gets.
Rebecca, thank you. Marcel from the J. Craig Vance Institute. What I find interesting is that you're bringing up is not just creating the structure, but the psychological framework, that will allow change. One example I could, just as a comment here, I could say is one time I participated as a volunteer in this community called Sense of Home. And they help homeless women have a home. But there's a difference between having a house, a building, versus a home, where you in the past people donated house or paid rent for house for homeless women, but they became homeless inside the house, again. And the sense of home was to actually build a community, so it became clear that it was more than just providing some sort of economical infrastructure. It required like a framework that was psychological, and going through, past problems and chains that were not broken, and the idea that the community was really important. So it really affected me and changed my perspective to see that not only we were going there and helping open the door for the house and but then, people were bringing the furniture, but then there was like a community participating. There was a schedule of activities, they were engaged in community activities themselves. The children were engaged into other events there. So yeah, I find this really interesting. I would like to, I was just making a comment, but also curious to hear more examples of what you think can really bring a change of the culture within the infrastructure that you're trying to change.
I mean, I think that, I don't know. I think that a lot of it is sort of this, the best place to begin, and I make no claims that I'm doing this perfectly or well, but I think that there is a lot of low-hanging fruit in that. I think it's very uncommon for folks to start by naming the values that are underlying their work, to sort of start by naming power structures in fields that have more of this biomedical framework. We are taught to be objective scientists who are naming a reality that already exists without our help, right? This is why, this drives me crazy, by the way. This is why some of our stuff is written in the passive voice, because like science was done and the objective truth was revealed, and like the scientist as a human being was not involved in it. And I cannot stand the passive voice in science, because it removes the human being from the science. A researcher did that. A researcher chose the question and the research design. And so I think that there are a lot of really smart people in other fields who have shown ways of doing this work that are cognizant of power structures, that are cognizant of sort of first doing the internal work, right? And I referenced Freire as kind of a paradigm, and Freire talks a lot about you have to be self-reflective yourself first, before, in his case, as an educator, before you go out and like try and mold young minds. And I think that there's a lot of interesting work happening in gender studies, in ethnic studies. A lot of the stuff that I'm referencing, I showed a picture of Bell Hooks, but a lot of the stuff that I'm referencing came out of sort of Black feminist scholarship, who are very, very good at naming power structures. And I think that there is so much for us to learn from other fields. Collaborating with folks in the Department of Education Studies has been really eye-opening for different ways of doing epistemology, different ways of understanding what's valuable. Collaborating with folks in ethnic studies and gender studies has just been a whole world of ways of thinking that I didn't even know were possible, and I'm just so excited to learn more about. And so I think that a lot of what I'm saying, we're still at a point of it beginning kind of at the individual researcher, and taking the time to think about how we are going about our own stuff, and also looking around to all of the other really smart people on our campus to see what they're doing, because I think there's been a lot of deep thinking going on about this in other spaces, and we don't necessarily have to reinvent the wheel. We just have to like, translate and implement it, and we can like study that if we want.
It's great. Anyone else have a question for Rebecca?
I mean, I think I'm getting out too far on the limb,
I love limbs.
but while I have you and can pick your brain with a sharp instrument, yeah. How could we do better in the setting of these structural determinants of health versus just calling them out? Like, what can researchers do to specifically propose the right hypotheses? I think I loved it when you framed it that way. I need you to talk to some of my students. And how can we drive that home, I guess, in terms of research? And just freewheel that if you could.
Yeah. I feel like 90% of what I say in any given meeting is like, I don't know what people need. What if we asked them? And I think that I know that a lot of us in HIV research are doing this already, but I think that the more that we can build authentic relationship and trust with the folks who we hope our research is going to serve, the better questions that we're going to ask. So I work a lot with a local refugee organization here in San Diego, and I feel like I am doing my best work and my best science when I am technical support. When they say, we are pretty sure that like climate change and housing are causing bad outcomes for our community. Can you help us understand that? And I say, yes, let's do it. And I'm really in a supporting role. I know that not all research can be participatory research, unfortunately. But I think that the more that the communities we want to work with have a meaningful role at the table, and by that I mean there is some form of accountability if what we're doing they think is not going to work, then somebody feels like if they speak up that they will actually be listened to. I think the more we can build in meaningful roles for people who are experiencing poor health as a translation of power, the more that we are going to ask better questions and do better science.
Okay, I think that's a great place to end on. So thank you for that.
Yeah.
Great.
Okay.
Thank you so much.
You're good, Steele?
Yeah,
Thanks,
we're good.
everybody. Good.
Thanks, everyone. We'll see you next month. We'll get more information on that soon.